Hi, everyone. I'm Ashley Wendel, and this is Lead Well MD, a podcast that explores how leaders can transform healthcare through effective clinician leadership. My guest today is Dr. Patrick Runnels from University Hospitals Cleveland, and we talk about what's fundamentally broken in healthcare right now, why the economic engine has become the why in medicine, and why that's so dangerous. We dig into what it actually means to lead with love, the difference between transactional and transformational leadership, and what it looks like when a system starts to change from the inside out. So lots to cover. Let's dig in. Today's conversation is about stepping back and asking a bigger question, which is how do we rethink leadership, culture, and the way that healthcare systems actually function? For many, we're still operating inside systems that were built for a different time, where we're prioritizing productivity over authentic purpose. We're prioritizing management over what I would consider real leadership. And today I'm joined by Dr. Patrick Runnels, who is the Chief Medical Officer of the Veale Initiative for Healthcare Innovation at University Hospitals Cleveland. So Patrick, thank you for being here.
Thrilled to be here. Thanks for having me, Ashley.
You bet. And I'm really looking forward to this conversation because I was lucky enough to hear you present a few months ago. And I think that the work that you're doing at UH is naming and addressing something that a lot of people in systems feel, but they don't necessarily have the language to talk about specifically. So I'm really excited to dive into some of these topics with you.
Yeah, me too.
Yeah, let's do it. But before we do that, I would love to hear a little bit more just about you and your journey and how you started and how you ended up doing the work you're doing. You're a psychiatrist by training, correct?
Yeah. So I'll encapsulate it as quickly as possible. I got interested in psychiatry and kind of fast forward, I was very interested in working with the homeless. In medical school, I did a rotation, was incredibly attracted to the work, the mission, the opportunity to impact the most marginalized folks. And so went to New York City for my training. And I thought, oh, I'll go to residency in New York City. There's lots of homelessness there. This will be a great place to learn. They must be the best at it in the world. What I discovered after being in New York for 2 years of my 4-year residency was, in fact, the system was wildly broken, that much of what we learned about the evidence and what we should be doing wasn't being applied. And that was true not just at the institution I was at, that was true all over. That was true in communities, community organizations, large health systems. And when I asked people about why that was, the message I got was very much, oh, yeah, we're not paid for X or this, or we don't have enough money.
Right.
But I looked at what wasn't being done, that didn't hold water with me. Meaning very clearly, well, we're not paid for that, but that this is free, or that's just doing the evidence different, or that's just talking with people. Shouldn't be so hard. And the conclusion I came to was that there is something amiss with leadership, that the folks that are in charge of designing systems, running systems, managing systems didn't feel empowered to do things differently than they had been done. And I think that's what you alluded to in your introduction there. We're kind of stuck. They were stuck in the world as it was. And the idea of breaking out of that in a meaningful way was not within their capabilities. It also wasn't in mine. So you learn that somewhere in the middle of residency, I made a decision to shift slightly from being a homeless outreach psychiatrist, walking on the streets,
Wow.
we'll give them sandwiches, to getting management training so I could make those systems better.
Wow.
I did a fellowship in public psychiatry at Columbia, and then I moved back to Cleveland, or not back to Cleveland, moved to Cleveland. And for the first 10 years of my career, I was the chief medical officer of a very large mental health system here, a community mental health center here in Cleveland, and got the opportunity to build the system differently. Got the workforce to behave differently, changed the way people interacted, shifted from it being silos to being interconnected teams that were managing populations, not just when they were in front of them. Built pharmacy, did all this really cool stuff. And after about 10 years of that, leadership changed. I needed to move on. And so I kind of returned to the Department of Psychiatry at UH. Long story short, ran into my boss, Peter Pronovost, who is an internationally renowned quality guy who had just been hired as the Chief Transformation Officer at University Hospitals. UH is a large health system. We serve something like 1.5 million unique folks every year. $7 billion business. And so I went from being this guy who thought of myself as a psychiatrist. Peter, after we met, pulled me into his work. I became the chief medical officer of population health. And for the last 8 years, I've been doing the same work, with a totally different system,
Wow.
with a much bigger system. And it's only reinforced what I thought was, this is a mental health problem. This is a community mental health problem. This is a problem for the systems that were built to treat people with schizophrenia. It turns out, nope, it's all of it. Doesn't matter if it's schizophrenia or addiction or diabetes or obesity or whatever.
Yep.
Systems are not designed to change with the knowledge that we're gaining in the work.
Wow.
And so that's the work I've been doing for the last 8 years. And it's
Wow.
been exciting.
Wow. So it truly is, it's a system problem, right?
Oh, yeah. Oh,
Yeah. It's a system problem.
Yeah.
That's fascinating to me. And that leads perfectly into the question I wanted to start with anyway, which was, from that perspective, what do you think is fundamentally broken in healthcare systems right now? If you could kind of nail it down.
So I'll answer that question in two spaces. The first is, it is absolutely the case that our system is designed to reward, financially reward doing things to people, right?
Right.
So, which when it was first designed, and again, you mentioned this, that made sense. Fixing things that are broken was like state of the art. It was awesome. Wait, we can do a surgery to fix your appendix being burst. This is amazing. This is really, really good. People don't die from that anymore. And so it was absolutely a reasonable way to design a system when it first came about.
Yeah.
But because we haven't evolved the way we're compensated, that's led people to just double down on doing more of waiting till you break and then fixing you when you break.
Right.
And so problem number one is we're paid to fix people when they're broken. We're not paid, in my mind, to do what we ought to be doing and what we now can do, which is ensure that people are as free as possible from the burden of disease, so that they're free to live their best possible lives.
Yeah.
That's different than fixing you when you're broken. It's different than that healing, which is so core to a lot of physicians.
Yeah.
The second piece, so that's how our systems are designed, and we're exactly for that. But as I kind of mentioned before, even though we're not exactly paid for that, it's not like we can't do a lot of that within the payment structures we have now. That can't think differently about how we organize things. And it's not that, and there are some value-based payments and things like this. So this is another ingredient. There's something else missing. And for me, that was a sense that, there's a tremendous literature and evidence base on what good transformational leadership looks like, what it means to do things. And the skills are not implemented and possibly not disseminated across healthcare systems today. We select for people to keep the ship going. Don't mess things up. Don't do things that are different. Whatever you do, don't change too much. The system's a little rigid, and we don't have leaders that are getting installed, in my opinion, or they're getting promoted, that are enough capable and comfortable with that transformational, transitional state, moving people into that space. So that's my diagnosis.
No, I got that. And it's funny, you just brought up a couple of things that I remember from the talk that I heard. There was one line that you said, the economic engine has become the why in healthcare, right? I mean, and that is so true. So we've lost that connection to real purpose in medicine, I think. And you were also talking about the difference between that kind of transactional, reactive state, trying to move to more of a authentic, purpose, value-driven culture, right? I mean, that's the work. The other thing that you said that really struck me is that you thought one of the biggest problems that healthcare has is a lack of good leaders. And that, of course, that's where I live and breathe in the work I do. So tell me more about what you meant about that.
And I want to slightly clarify that exactly what I said was the lack of good leadership, which is
correct. You did say lack of good leadership.
And I want to be clear that I think there are a lot of really great leaders, and I've seen this, I've heard this happen. I hear these tales all the time. Really great leaders who get into the C-suite.
Yeah.
And immediately drop all the things that made them really good because of the pressure of the quarter, the pressure of the financial budget, right?
Yep.
So there is something to the weight of having a budget in front of you, being responsible for the well-being of the finances of the system, that change people's approach to the work they're doing and immediately have them get conservative really quickly with how they approach this. And again, having that responsibility is sobering, and it is important to be a good steward. But then people, I think, learn the wrong lesson, which is that, well, then I can't take risks. I can't take chances. I can't have a transformational vision. There's much at stake.
Right.
And may gum up. And so to that end, I believe there's more capability within the leaders that exist today, but I think it's not activated. And I do think we do a bad job of disseminating and helping people understand what that would look like and facilitating they're engaging in that kind of leadership. And the last thing I'll say about that is I do think that the examples out there of people doing it differently are small enough that a lot of people don't have faith that the evidence base is true, right? So if the evidence base talks about, and I'll use this phrase, if what the evidence base says is that great leaders are not expert deciders, they're actually enabler facilitators.
Correct.
And I would, just to drill into that, in physician land, and I'll just talk about physicians, we are successful by way of being experts. We are successful by way of being really, really good at a thing. And we're really, really good at a thing. People defer to us and they put us in positions of authority. And we learn over and over again that what people want from us is our expertise. That happens, and those signals are coming at us all the time. And the pressure to be an expert at everything all the time is central to our clinical roles. But then we fail when we move to the non-clinical, administrative and leadership roles. To then say, wait a minute, maybe we don't need to be experts here. Maybe we can't be experts at everything. Deciding. And then we think our job is to be in control of all the decisions and we have to control everything. And then that's the way you succeed. And I think that role set is baked into how we are. And we fail then to recognize great leadership by the evidence isn't being an expert. Great leadership isn't deciding. It's not that hard. Great leadership is enabling and facilitating, is helping others do great work. That is what the evidence says. And we lose that somewhere in that journey.
Oh, it's so true. If I could pick the top thing that I have worked hardest on with leaders over the last 2 decades, it's that particular point. I do a program called Leaders Coach where we're trying to shift people's mindsets, right? One of the biggest sticking points that leaders have, that these docs have, they're sitting in the room going, why is it so hard for me to not just give them a solution, to jump in and tell them what to do? It's so ingrained. And so I spend a lot of time teaching them how to just take that moment, be more mindful about it, take that clinical hat expert off in that moment. It is such a difficult shift for people. But when they're able to, and they see the ability to, it can be so transformational for them. So I love that you bring that up. Yeah.
Well, just to add a little to that, it's not just them. Physicians have an instinct towards that, but the world is throwing signals at us too. And I have this happen to me. Peter has this happen all the time. Is people sit down with him and they want him to be an expert decider. There's this massive suck noise towards, please give us great ideas, please be innovative and amaze us. And so even though his instinct is, no, I want to facilitate you. The world also demands that. And so it's both those forces working together that make it really hard.
Yeah, that's a good point. That's a really good point, actually.
Yeah.
So let's get back to that whole thing about the higher purpose. So you have a very clear mission that you just mentioned a few minutes ago at UH, right? About helping people live their best lives, right? Stay away from disease. It's much more preventative, which I love. Why do you think that's so important right now in healthcare? And I mean, is it possible to live to that higher purpose?
So that from organizational perspective, we have tons of evidence. So if you talk to most providers, clinicians of any stripe, like you can talk to our finance people. If you talk to finance people, we know a lot about how to prevent things, which is it possible? Yes, we know a lot more than we did. We can do a lot of stuff. As just a couple small examples. And this is not just our health system. I'm using our health system's results, but we're not the only ones that did this.
Right.
If you start screening for colon cancer more, and we increased our colon cancer screening by like 30% over the course of a few years. We saw a 50% reduction or so in our colorectal cancer surgeries.
Wow.
You just get people's colon cancer screening, and that's as much as that little card you do in the mail. You see massive reductions in the downstream thing, right? In the downstream utilization.
Right.
By the same token, it turns out that if you give people medications and make sure they're enabled to have their medications, their diabetes is in better control. And we've seen our diabetes control improve by way of having pharmacists get involved in the care. And it wasn't rocket science. It wasn't this massive thing that we don't know how to do. It's been in the literature for years. We now know stuff we didn't know 40 or 50 years ago. And we have successfully experimented with those things. So the question isn't that it's not doable. The question is, now what is harder to imagine are two things. The first is you can't flip a switch and just be that system on day one.
Right.
If you've wired a system to wait for people to break and then to try to fix them, if that's how your system's wired, the work of kind of rewiring. Because, by the way, sometimes I break my arm. Now all I want is for someone to fix my arm, right? But if that process of rewiring, that is a cultural change, that is workflow work, that is years of work. That's rewiring so that you're getting a new memory a muscle memory for what you do well. And the right answer is no, we're not just going to be over there tomorrow. The right answer is this is a journey.
Yeah.
So of our health system, we think that journey is somewhere in the 5 to 10 year range. And we coach did. And so we started by taking little small bites. Let's start with primary care. Let's see what happens. Let's start with length of stay in hospital, see what we can bite off.
Right.
We did that. What we found is that got us better and better at interacting across silos. And it got us better and better at some of the bigger risk taking to try new things at small scale and see how it went.
Right.
And but those initial silos, whether it's IT and finance and a clinical department and all this, they're not built to collaborate in most systems, not built to trust each other. That's the part that actually takes a long time.
Right.
And so, to that end, that I think that answers your question. I may have missed something in there, but
No, it does. No, it's so interesting. And one, I appreciate the length of time that it takes, because I think people want to do this. They want to see results like that. But we know culture doesn't shift like that. People don't change like that. It takes time and energy and intention.
Yep.
When you started doing this work in your own organization, I'm very curious, how did leaders start to show up differently, or did they? I mean, where did you see the small changes happening? Yeah.
So I'll just use one example. Pretty early on, one of the things we decided to do is, we need to do more annual wellness visits in primary care.
Okay.
Annual wellness visits are the place where, instead of being there to fix problem, I'm there to kind of go through, hey, how are you in your immunizations and your screens and your, is everything, how you doing? Okay, so we need to do more annual wellness visits. Now, that was not a typical thing that most primary care docs even thought about. Like, it's not that they didn't think about, were you doing well? It's they didn't think about making sure that everyone they saw had an annual time to come in and sit down and check.
Right.
So we did it. All we did is say, let's just get as many people into the annual wellness visits as possible. And that was a simple thing that the leadership of the Primary Care Institute, our organization, said, well, yeah, we could do that. Okay. And we built a bit of a financial case to say, this is actually will generate some revenue. And so it's not going to break our backs, but it was a very simple thing. Can we get as many people as possible in for that? And the short answer is we did a campaign over 3 years and went from something like 20% to something like 75 or 80%.
Wow. Okay.
So, and the thing about that is the leadership was bought into it, but as soon as the providers had good reason to push back, and they did have good reasons why they wanted to push back, the initial response was hesitancy. Let's hold this off, or maybe they got a point, but it required senior leaders to say, no, we want to go here. And we don't want to discount those voices or push over them. We want to hold those people into the conversation, understand what's going on, and see what we can do to improve that. And what that led is to the first year, we didn't do all that well at changing things, but we learned a lot and got a lot of little iterative things going. And by the second year, we were then really launching into really great work.
Can I ask, what were some of the initial pushbacks that you got from that? I'm curious.
Oh, any primary care doc will tell you this. I have, I don't know, 1,000 people or 2,000 people on my panel. Yeah. They're calling in for sick visits all the time. An annual wellness visit is a longer visit that I'm doing on top of the regular care I have to do.
Right.
And that every time I pull someone in for a 20 or 30-minute annual wellness visit, that means 2 or 3 other people didn't get in to get their acute needs met. And by the way, my patients stay with me because I'm responsive. So if I'm not responsive to that stuff and you're taking away that avenue, then I can't be responsive in the way that are what people stay with me for. Right.
So what shifted? What shifted to get them engaged?
So I never think so. Like anything, several people said, sure, I'll give it a try. Did it and realized that they still had enough time and space to do the good work they wanted to do. In fact, to a point you made, instead of being reactive, this allowed them to be proactive and address the problems up front and reduce problems down the road. Right.
Maybe less sick visits. Yeah,
exactly. The system decided to add some team members to make it more possible. So we're going to give you a little few more MAs. We're going to add some nurses. We're going to actually add a social worker for behavioral health. Like they added some resources. And by the way, the extra money we're generating from this, we're going to use to cover those resources.
Right.
Which meant the docs were more free to do that kind of stuff. But just to be very clear, that meant, and this was actually the biggest thing, that doctors had to think differently about what they were for. So before, the identity of the primary care doc was, I have to be in front of everybody and know everything about everybody all the time.
Right.
Was, no, you got a team now, and the team's going to allow you to manage this capacity in a different way. That means seeding a little bit of that to team members who you trust. And so that ended up being the thing that took more time and more work. But once we got models for that going and people started to feel comfortable with that, we could then go back to the laggards and say, hey, this we're doing, this is how we're doing it. We need you to come along. And then we worked with individuals who were on the back end of that.
Isn't it so interesting how so often, and this is true, I've experienced this in all facets of the work I do, it comes down to human dynamics so often.
The instinct for a lot of people was to say, you just need to do this.
Right.
Can't tell you.
It goes well.
Well, and I came in right as that initiative was underway, but I had conversations with docs mad and, okay, I'm the CMO of Pop Health. I'll talk to you. And I'm just a psychiatrist. I was not part of their world, and called me to complain. And all I did was listen and say, I get that. And I understand why that's hard.
Yeah.
What can I do to help you feel good about the transition?
Right.
They often said, nah, just listening to me was enough. And then 5 weeks later, they had moved, which is to say, it was listening and it was listening to them and being present and hearing them and making sure they understood it was okay to be upset.
Right.
And so often that led to people, oh, now I feel heard. Someone got me and they chewed out. They said, oh, no, maybe I can do this.
Right.
That was that lesson is so powerful. It's not that sometimes you don't have to tell people what to do, and it's not that you sometimes don't have to hold people to account, but that actually is the last step. There's all the stuff you should do beforehand, and that other stuff. The other stuff, most people come along.
Right. So you're seeing over time, how long has it been since this whole kind of effort launched within your organization?
I would say we properly launched our initial foray into this in 2018. So it was at 8 years, and started heavily in primary care for a number of years, and performance there to be better. And over the last few years, we've moved heavily, and then we moved into hospitals, general hospitals and hospitals. And last few years, we moved into the specialty spaces, and not remotely perfect, but way better than we had been, and a lot more confident of what we can do within the constraints of the system as it is.
What are you seeing that makes you think we are absolutely on the right path here?
A couple signals. The first and foremost is the naysaying about doing high value care has downshifted, and our CEO, really supportive, but our CEO went from this being a side thing to this being everything he talks about. So like the CEO bought in. The CEO bought in because we got good results. When the CEO is saying our North Star is high value care, that's what we are, as we endeavor to be a high value system. So that ability for that language to pepper in so everyone's hearing it on every, communicates and talks, right? That's thing number one. Thing number two, the flip side of that is you hear that, but you also, as success started to accumulate and we started seeing results, and we relentlessly shared our successes. By the way, we also relentlessly shared our failures and talked about what we got out of the failures.
Nice.
Practice used in a lot of other companies like Google and Pixar, but we relentlessly shared our success and we spread the word. And as people saw one success, they started having more confidence that they could do well as well. And felt more, oh, well, that was also a bit of a risk. I can take a bit of a risk. I can try something a little different. And they're more likely to do that. And that was the confidence of you build one success and then pretty standard stuff. Oh, well, maybe this is okay. Maybe we can try a second thing. Well, now we've done 3 things. Well, maybe we can try this in a different space.
Right.
So the confidence of the people, and it was very infectious. You could see people flip. Oh, wait, no, we can do high value care. We can do this. I'm into the vision. Let's go. Right. And it was that was what happened. And all along, the transformation leaders were consistent about here's where we're going. Getting us there, but here's where we're going.
That's right. Yeah.
So
what's interesting to me is the way that you frame this inside your organization. Because I listened to you for the first time when you were speaking to the Loving Organization Consortium. There is a crossover with this concept of leading in a loving fashion, right? So where does that fit in the overall mission that you have at UH? Because I know that Peter is all over that. The love concept is big. How do you feel about that? Where does that fit in practice in what you're doing in the organization?
So I'll start with the foundational concept. Love, as we often use that word, and we do use that word a lot in our organization, is about unconditional regard. It's a belief that people are capable and to expect the best from them.
Yeah.
To unpack that a little, it is not uncommon for me to encounter leaders in C-suites who believe that the people they are leading are self-interested actors who will only operate optimally if they're pushed to do so.
Right.
And what they see in them are the flaws they have, right?
Right.
Or their deficits, right? And so at its core, what we communicate over and over again when we say lead with love is we believe deeply in the capabilities of the folks. In fact, we believe you all have way more capabilities to lead how we're going to transform than we do. And we need you to do that. And we trust you to do that. And we're going to enable you to do that.
Right.
Is at its most core foundation what we're talking about. Within that is something that we say all the time, which is that leading with love, and a different way of saying that is being humbled and compassionate.
Right.
The humility part of that, I am not the expert of this. You know, our CEO our CEO is an ENT surgeon. He's really ENT.
Yeah.
He is terrible at psychiatry. That is not his. He absolutely needs to set the North Star, but he shouldn't be going and mucking around saying this is exactly what you do here or there, right?
Right.
And,
Right.
and that's not a knock on him. That's just an example. All leaders are like that. And going through and saying, we aren't the experts. We probably have most of the answers. We have responsibility to be good stewards. It is about kind of elevating that in people and that humility. And when people see that you're not there to dictate what to do,
Right.
different than we're dictating where we're going. It is absolutely leader's job to say, here's the vision and we're going here. And you may not like it, but this is where we got to go. Very different than here's how we have to do it.
That's right. Yeah. Yeah.
So you give people leeway to determine the how to some extent, if they can.
Yeah, no, we'll go back, like, well, that's way off base. We'll go back. Well, maybe you might be a little off here, but again, it's more of a, hey, you're off. Let's reorient and understand where you're at. Let's figure out what's going on with that.
Right.
Most of the time they knock it out of the park. Once you put trust in people, it gets back to something else you said. And I think, relationships matter so, so deeply in this world. Belonging matters so deeply. Our broad kind of leadership framework, which we call leading with love, has three components: believing, belonging, and building. Building is the tools you need. It's having good data systems. It's making sure that you have time set aside for meetings. It's project management. It's all that kind of stuff, right?
Sure.
It's tracking what you're doing. Believe is getting people bought in to two things. A, the direction we're going is good. And I'm going to paint a story of where we're going that is compelling, that you'll want to go on and you'll devote yourself to. But it's also believing that I have a role in that. Not only that I have a role to play, and the system believes I have a role to play. Then there's this belonging piece. And the belonging piece, which is in the middle of that sandwich, but is the most critical thing, is take out the content of the building and the believing. Belonging is this idea of, do I fit? Are these my people? Do these people depend on me? Do I depend on them?
Right.
That interplay between I'm needed and I am cared for by those I work with.
Right.
That matters. When you see silos pop up in health systems, what you often see are people rallying around belonging within the silo, but with this idea that outside of that silo is kind of the enemy. IT's doing good work if only finance didn't do this, if these clinics, and it is shifting that to no. When the belonging circle can grow, and it's the feeling that, wait a minute, if we actually create intentional space so that you first and foremost feel seen, heard, and valued by others, that the rest of it comes along.
Right.
That I think matters so, so deeply to what we're talking about.
Yeah. And I think, like a colleague of mine says, it's whether or not people make that choice, whether they're going to put in their discretionary effort at that point. Like, am I really going to spend my time in this? That and belonging piece is such a huge part. I think if they feel included, but also if they feel like what they say is valued enough to have action taken on it. Do people really hear me? Do they follow up? Does my voice matter? Yeah. Spent a lot of time with that.
Yeah. And you don't have to agree or approve of everything someone says.
No.
But they have to feel like they were heard.
Yeah.
And it's important that your leaders hear them, but it's almost more important that the people around them accept them and believe deeply in their capabilities.
Right. So that takes time, though. That's the cultural shift that takes time.
Yeah. But there's times when you go to unlock it. Peter tells a story, my boss.
Yeah.
very simple story where he was doing rounds in one of the units, and there was a woman that was cleaning the rooms that was there doing the work, and he got talking to her a little bit, and he asked her what she does, and she said, I clean rooms, and sorry I'm in your way. And he said, no, the cleaning rooms is like this really important part of what we do.
is.
This is one of the most important things we do. If the rooms are not clean, people get infected. We look terrible.
Yeah.
And he gave her like a little 1 minute, here's what we're doing. Here's what you provide for us. This is why this matters. Okay. And he showed her a result, like we just did this. So walks away, he comes back a month later, and she pulls him aside and says, I just want to say that meant the world to me, because I used to go home and tell my kids what I did with shame. And now I go home and I bring home the results of how our unit's doing in terms of reducing length of stay and improving and reducing infections. And I say, that's my job. And I put it and I tell my kids.
Wow, that's amazing. I love that.
Yeah.
I really love that. You know, a few years back, I spent about 4 months daily in the hospital because my father was really ill before he passed away. And I have never gotten such an appreciation for every single role in, the health system that keeps things going, the entirety of it, from the person who comes to clean the room, everything, the lift to everything. It's just an incredible thing. And so people, if they can feel as valued as they are, especially by people on this side, that's profound. I love that. I love that he did that. And what an amazing way for her to shift her thinking about that. It's so great.
Yeah. And 5-minute intervention, right?
Right. Exactly. Impressive. Well, okay. So one of the things you also brought up that I want to ask you about is the development efforts that you make within your organization to help build your leadership capability. And you talked about this model, the 4 C's model. Can you tell me a little bit more about that and how it evolved, how it came about, and why that?
Right. So there is a body of literature. I won't get into that too much, but in order to get people to move, in order to get organizations to move into, for leaders, but also those within the organization to move, there are different levers you can pull. We've kind of created a little bit of a kind of a mnemonic, if you will, to describe that. The mnemonic is 4 C's, and C, that's culture, what we call cohorting, co-designing, and then co-creation. Our culture, we have 6 R's that we put in there, and those R's are rhetoric. What language are you using? Language matters deeply, and the repeated use of language matters deeply.
It does.
What rituals do you have? So what are you doing to emphasize the values that you want people to have and the types of activities and actions you want people to take? And those are everything from sharing success stories of patients doing well to just high-fiving people, giving, you well, and there's a lot that can go in there. Rewards and recognition, which are slightly different, but if you set people up with true rewards like bonuses that reward, say, volume, you've got to be mindful that that's going to maybe cut against some of the other things you want to do. And so you just have to be mindful about rewards you're giving out. And by the same token, that recognition, which can overlap a little, is what you recognize is what people remember. And so if you're saying, way to go on a thing that you want people to do, other people are watching that, everyone's going to understand that, and that's going to matter. The flip side, recognition also is being paid attention to. So the story I told of the custodial worker, recognition was saying, I see you. So
I see your value. I see how important you are. Yeah.
Right. Role modeling, which can be hard, but matters and is often really what leaders ought to be doing. Not saying here's what to do, but just, I'm going to try to show you, I'm going to represent what I think you ought to be doing. And I'm going to always be having that hat on. I'm always going to be having the hat of enabling and facilitating. I'm always going to be pushing toward that. I'm always going to try to demonstrate as much as I can, getting away from commanding, controlling, and berating.
Yeah. And I always tell people when they're trying to develop themselves in this process that it's about progress, not perfection, because people hold themselves to a high account.
Well, understanding, and if you don't make progress, why didn't you make progress? What's going on? Experiments matter, and the failed ones matter often more than the ones that succeed.
Very much.
And then relationships, and making sure that those relationships are preserved and supported. And a big one is there is space built in for people to develop relationships with those they otherwise wouldn't.
Right.
We really fail in healthcare on this with our clinicians. So what you hear all the time is, our clinicians are our economic engine. And so every minute of the day should be towards doing billable work. The problem with that isn't that it's not right economically in a certain sense in the short term, but when you take any worker, and this is called the capacity trap or the capabilities trap. When you take any worker and you put them into a space where they have no time to develop the future, you're taking their innovation offline. And when you take their innovation offline, you are not building capacity for what the future brings, and your production will stall out. So the more you push productivity to the point where people have no time to do any relating to anybody, you're going to look great for a quarter or two, or maybe even a year or two, but you are mortgaging the future of what you can and should be. And that is a hard lesson for leaders to learn, that productivity matters. You want to be right, but you also have to deliberately set time aside for people.
Yeah, that'd be a hard mindset shift to make, I think, for a lot of people, to shift away from that idea. Yeah.
Well, and in academic centers, we do a little better with this, but we're also often less successful. And yeah, the goal of that, though, is that if people have an opportunity, just a little bit of their day to do that work, they actually pay it back, and they're way more generative down the road. Turnover was down. There aren't the rewards come back to you, but take 2 or 3 years. And so it is a long mind game. And if you've already invested in everyone being productive every second they're at work, when you look back, there's a little bit of pain in that. And we've painted ourselves into.
Of course. That's right. That's right. And I think about how that would help with burnout too. I would imagine that if you give people time to step back and actually think creatively about things, it would just be such a refreshing piece of their work, I would imagine.
Burnout is related highly related to your belief that you have control over the system in which you work, or your influence, and your connectivity to people.
That's right.
You can have a great clinical practice and have connectivity to people within the clinical practice. And so sometimes that goes fine, and that's all some clinicians need. But the degree to which you cut out the ability to have influence over the system outside and never let anybody do that is the degree to which you're going to see burnout go up. And by the way, 50% across all caregiver groups. So we've done that to ourselves. And that's happened over the last 15 to 20 years with the massive emphasis on wringing every last bit of productivity out of everyone. And look, if I was to tell you, hey, I've got industry, and the way the industry works right now is that 50% of the people have high-level burnout. People coming into the industry would say, that's not an industry I want to get into. That's a bad bet, right? Healthcare, for a lot of reasons, is sticky. It's not going where we need it. So I think that behavior has been something people get away with longer than in other industries, but it's there.
So you and I are both very passionate, but how do we change it? How do we change it?
So the other thing, capabilities is easy. It's giving people education on what the capabilities are. So here's what good leadership looks like. Here's what great culture and teamwork looks like. And then not just saying it, but demonstrating it. And what I mean by demonstrating is I can give you all the information. If I, the leader, am not executing and doing what it says, then you're getting a mixed message. The flip side of it is if you're learning content and then you're seeing your leaders do the thing.
Yes, of course.
So that matters.
Yeah.
Supporting, belonging. So belonging in the change matters. We lean into peer coaching for our leaders a whole lot, and protect time for people to do that level of peer collaboration.
Can I just say something about that, Patrick? Because I think that's one of the things that a lot of organizations, it's hard for them to understand the value of that. Because, pulling your clinicians off for a certain period of time, to be together in a room, sometimes people don't want to invest that time. But I know how important that is too. You see it when you see people together for any length of time, how critical that is.
It's interesting. So take a large health system out of the way, and just so there's a primary care practices were typically small private practices. And what the docs who owned those practices often would do is set it up so that they're as efficient as possible. Let's have as few people helping me as possible because those are costs. So let's minimize the MA ratio. And then don't have team meetings. And I've talked with people who would say every team meeting was money out of my pocket. I could see it. It gave me great pain. And so that's happened. The instinct toward that is so strong. Every hour of teamwork is an hour of billing I don't collect. And I see that in my paycheck, or I see that in our financial bottom line, is a really hard pull to get over. And again, to the point we're making, but it is not just saying be free.
Right.
It's being intentional about what that space looks like. So it's not just give people space. It makes sure that space is for the betterment of them and of the company. Right. And it is, so you can curate that space. You can make sure it's good. And the peer coaching piece of it, look, that's, people will get together for drinks after hours, like whatever that looks like. an hour a month of that can go well. Where organizations do that badly is what they think peer coaching is I'm going to set you up with another person and you're just going to get to know each other. It's going to be awesome.
Right.
But great peer coaching actually requires a little bit of training and a little
It
bit
does.
and it is better if it's curated amongst a distinctive group, not just two people that you give responsibility to them, but you actually keep it up for them. And we've seen a lot more success when we cue people and say, nope, this 5 people, your peer coaching group, we're going to actually do some exercises with you so you understand what this is. Then we're going to check in with you regularly to make sure. Structure built, but
No, I agree entirely because it's not just getting together for beer and commiserating. That's not coaching. I mean,
that's not coaching, right? Yeah.
Yeah.
So, and then the last piece, co-creation, is making sure people have opportunities to do the actual work of change, right?
Right.
And doing that work alongside them so that they are building skills around transformation while they're doing it. It's the practice part. If you teach people all the things in the world and you say all the great things, but no one has any time to practice, and by the way, fail.
Right.
Failing is a big deal. It's okay to fail. Hey, you did a project and you're not doing great. That's okay. Everyone doesn't do good the first time. I'm here. I'm going to help you. I'm going to pick you up, and you've learned. And now next time you'll be that.
Yeah.
People are afraid. We punish people so quickly for any perceived transgression or mistake.
Right.
It is built into the DNA of a lot of places, and clinical land. The thing I hear particularly from surgeons a lot is, but one mistake and people die, and you have to get rid. And the reality is that's true. And high pressure matters, and it's not always easy to be your best self. But you can practice this stuff so that not what's going on, or that it's mitigated, or that people trust you despite it. All the research on when commanding leadership works well suggests that it only works when you've done the pre-work of getting people to trust themselves as a team. Someone has to shift in commanding mode, and ordering people around because they are hard happening, that they built the trust already and they lean into the previous trust. You start yelling at people and ordering them what to do.
Right. And I know it's harder. I mean, you're talking about psychological safety, of course. I mean, we focus on that all the time and the criticality of that, but it's harder when teams change a lot. You don't get that opportunity to be intact enough to build that trust, but it's helping people have the skills to be able to build it quickly with changing groups so that you can, because you're absolutely right. You have to have a baseline before you can.
And systems can just invest in that up front. Not a lot of investment.
No.
And then it does well. And by the team turnover thing is a problem we've created because we don't nurture this. And turnover is a cost. I think every nurse turnover in our system is $300K.
Oh yeah. And physicians? $1 million?
Really not. I think so. I that's what I understand, especially for physician positions.
Yeah.
And so that's an awesome dollar you saved over here, but that dollar you saved over here, you just lost $1 million because that person. Wow.
Right? Exactly. No, I got you. So interesting, all of this. I mean, literally, I could talk to you for hours, but let me ask you just a couple other things before I wrap up. But so this shift that we're trying to make from this very transactional to much more transformational leadership and trying to shift the culture, what's the downside if we don't do this? Really, what's the consequence do you see if this doesn't start happening in more places?
So this is me opining a little. So to be very clear, I'm not everybody agrees with me. So the date point I'll give to people is when the Affordable Care Act was passed and enacted starting in 2010. Well, a lot of people don't know, and I haven't looked at this last year's data, but it's from 2010 to 2025 or 2004 or whenever we have it. The percentage of dollars we spend on healthcare as a percentage of GDP in the United States has been flat. It's been the same, meaning we're between 17 and 18%. So not that healthcare spending is a lot. It's not that it's not hard. But we haven't increased the amount of dollars we spent. And the reason for that is we don't have any more dollars to spend. Healthcare bankruptcy is the number one form of personal bankruptcy. Paying for healthcare is actually the number one cause of economic anxiety amongst the populace, so on and so forth, right? So both healthcare is unaffordable as it exists right now. It is causing increasing amounts of bankruptcy, and we are not spending anymore. Healthcare, as it's been built, has survived with the idea that we can always just keep getting more and more GDP. If you look about the healthcare spending over the course of time from 1975 to 2010, we just kept charging more. We grew faster than inflation. And as a result, we sucked up more and more of the dollars. And what I think the data the last 15 years, that is, the world doesn't have an appetite for that anymore, which means what you can't do anymore is just keep bumping the prices up.
Right.
Means that if you don't start doing business differently,
right,
costs are going to outpace you and you're going to fail as a business.
Uh-huh.
What I would say is, if we like to think of it as a choice, there are definitely leaders out there who say, I'll believe it when I see it, and
Right.
I'll react once the change happens. But I believe those that don't proactively change and transform to do something that creates more value for patients by getting better outcomes at lower cost, I actually think we're going to see a lot of hospitals in a lot of financial trouble over the next 5 years. It's just not doable anymore. It's not sustainable.
Right.
There are things that, you can only do surgeries in so many places, but I have seen a lot of market entrants starting to nibble away at the parts and places and pieces of this.
Right.
The change will come.
I think also, do you see more physicians getting engaged in that conversation and really starting to understand the financials and the value base and the equation that accompanies that to understand the changes?
I'll go you one better. Talk to any group of physicians under the age of 40. They came in knowing it wasn't working and deeply believing that they wouldn't have a voice, but as soon as you give them a space, will deeply run right towards you, meaning this is what they wanted to see. They felt disillusioned before they got done with med school. They were disillusioned. That's surgeons, that's primary care doctors, it's all. And which is to say, they want this to happen. They want their practices to be more fulfilled. They want the change to happen. And as soon as you put the light up and say, let's go, they run toward it.
What about the docs over 40?
It's a mixed bag. If you're in retirement, you've done things your whole life, maybe this kind of transformation isn't awesome. But many of people on the older side, I'm 50, so clearly I'm into this. But what I'll say is, the further up you get in the leadership change, the more people start to get conservative about this. And it's funny, this inverted pyramid. The people at the bottom are like, let's change.
Let's do this.
Both of them are with good intention, but I think most people want this to be where we go. Most people, especially those who are going to be practicing longer, see the future as being quite different, and they will happen.
Okay, so last question on a hopeful note. What's the future that you want to see? And if you were coaching somebody, a leader in another organization, of like how to start this, how to start making change in their own organization, what would you say?
The future I want to see, to answer that relatively briefly, I want to see at least one health system shift so that everything they do is oriented around high value, and they're doing well, and they're sustaining, and they're growing, thriving. It is that simple. If one system does it, it will get duplicated. But I want to see one system do it. And me and the folks I work with, we're very committed to our system being that, but we're committed to any system that wants to get in the game. And I believe it's doable. And I think I'm seeing the shoots, right? The second question you asked,
how would you coach somebody if they wanted to start a leader wanting to make change? Where would they start?
Be clear about where you're going. That is not about the financial picture. What is your value to the world? This goes back to authentic purpose. Why do you exist? Why should people want this? And it used to be that you could say, well, people want surgeries, and it's good enough. But I don't think that's good enough anymore. Start with, why does the world want you? Don't start with how you're making money. Don't start with how you're staying alive. What ought the world, and not just what does the world want from you, but what would or should the world want? And think about it as going to that space, whether it's 1 year or 10 years. What ought the world have? What does the world need? What can you provide that improve the value in the lives of folks around you, not just what will keep you in business? Once you get that, then go to, who do you need to have around you, and how do you need them to behave? And what do you need to change, and how do you empower those people? Those two things. You'll need coaching, you'll need mentors, you'll need care, you'll need all of that.
Development.
But those two things.
And
you'll make those mistakes. That's fine.
Create the space for that. I love that you just shifted what you were saying. You said, how do you want those people to change? And you said, how do you empower those people? Because it's so different than telling people what they need to do to change and saying, here's the vision. How can we get you there? What are we going to do together to get you there?
Patrick Lencioni's book was the 5 lessons a team. The little fable.
5 dysfunctions, or the 5.
Dysfunctions team. It's this little 100-page fable.
Beautiful.
He was just a consultant. He is not an evidence-based leader. He just said, I did this for a lot of years. Here's what I think. And he wrote a story. And the fable centers around a woman who's in an industry of which she has no expertise, but understands deeply that team matters and that empowering is actually her job. And it's simple. It's like an 80-page story. Yeah.
Now, I teach his stuff all the time. I love his stuff. And now he's shifted to more of the 5 behaviors around how do you get out of the dysfunctions. But the first thing is actually, understanding them and seeing where you are and assessing.
I think, like we said in this, it's being able to see it. It's what does it and feel like matters almost as much as knowing steps. Right?
That's right. That's right. Oh my goodness, Patrick, thank you so much for this conversation. I feel it's very encouraging to hear organizations that are really doing this and doing this well. And I know it takes time and you have such passion around it. It's really fun to listen to you. So I really appreciate you coming on and sharing your thoughts and stories around this.
Ashley, I love coming on and talking, as you can tell. And no, it's been a pleasure. It's been great to get to know you a little bit more. And I'll do it anytime. Just call me up.
All right, Patrick. Thanks so much.
You're welcome.
Take care. Bye.
Bye.
Thanks, everyone, for listening today. What I keep coming back to is something that Patrick said, that when you give physicians a space to move towards something better, they run toward it. They run. That feels both like the challenge and the invitation to every leader listening to this right now. If today's conversation sparks something for you, I would love to hear about it. You can find us at physicianleadergroup.com or on LinkedIn. And if you're working on leadership development inside your organization and wondering where to start, reach out. That's exactly the work that we do. And if this episode was useful, please share it with a colleague. Could be a physician stepping into a leadership role, or a CMO that you know wrestling with culture change, or anyone who believes that how we lead in healthcare actually matters and needs to change, because it does. So take care of your people, take care of yourselves, and I'll see you next time. Lead Well MD is produced by Ashley Wendel and Physician Leader Group. Get new episodes as soon as they're published by following Lead Well MD on your favorite podcast app. And don't forget to share with your colleagues and spread the word.